So when I accepted to speak here, I thought it would be a small, intimate gathering. I wasn't expecting to see so many GPs, but I'm absolutely delighted to see you all. I'm Eleanor, Dr. Minshall, one of the paediatric allergy consultants from Sheffield Children's Hospital. And I'm here today just to talk about our paediatric allergy service, but also hopefully guide you through the presentations of allergy, how to manage it, when to refer, when not to refer, and what to do if you're faced with a child with a paediatric food allergy. So those are just a list of what I'm going to go through. You will get my slides at the end, so I'm not going to go through that. Just to say that just important to keep children safe while they're waiting for their appointment. Currently, our appointments, there's two types of appointment, really, unless you're urgent, in which case we'll see you within 2 weeks. We see children with an egg allergy under 1 year of age. We see those soon. And the reason we see those soon is that actually egg allergy is a predisposing factor towards peanut allergy. And so we want to see them soon to actually make sure that they've got peanut in their diet. We generally see children under 1 soon. Everybody else waits our standard waiting time, and that has been up to 8 to 9 months over the last couple of years. We're trying to get it down, but certainly if you refer for a drug allergy clinic, our waiting time is sort of 9 to 10 months, but again, we're working on that. So when to prescribe adrenaline autoinjectors, and just briefly how to give them, food avoidance, and our contact detail and how to get help. So these are the sort of things that actually we want to see. So we will take any child with a history of an immediate food allergy, and I'll go through what constitutes a good history and kind of what to put in the referral. We will see any child with a severe delayed reaction, and by this I mean FPIES. FPIES is incredibly rare, and generally it's a diagnosis made in hospital because the child, invariably under 1 year of age, presents with delayed, persistent vomiting. Vomiting sufficient enough to become pale, floppy, needing oral or IV rehydration. And generally they'll suffer from kind of numerous episodes of this, generally caused by foods, and not foods that you would normally think of as food-induced allergic reactions. So things like chicken and rice are typical for FPIES. You may see it in adults. Adults, it tends to be more shellfish. Early onset eczema, so we'll generally see any child with early onset severe eczema with SCORADs greater than 40 or needing topical corticosteroids, particularly on a regular basis, particularly if they're breastfed. And there's a suspicion that foods are triggering their eczema. We'll naturally see anaphylaxis. Those normally present to our ED unit, and we'll see them either on the ward or very soon afterwards. Hay fever, I'm not going to be talking about hay fever. I'm happy to go through hay fever. I have put the local guidelines up. If you're not aware of that, I can, I think at the end there's a link to the kind of ICB guidelines. Happy to see chronic spontaneous urticaria. That's urticaria that has been evident for more than 6 weeks, particularly if it's not responsive to sort of maximal medical therapy. And our maximal medical therapy is a second generation antihistamine, so not Piriton, something like cetirizine, loratadine, fexofenadine, at a higher dose than you would normally prescribe, so up to 4 times the BNF dose. We'll see an idiopathic anaphylaxis, and then if there's a suspicion of a drug or vaccine allergy. And this is just a graph showing you how our referral rate has been over the last 15 years. So increasing from just above 1,000 to now 1,800 children. And in that time, we have grown our service. There's now 5 pediatric allergists, part-time, full-time. So, history taking. So when we think about food allergy, we want to have a good history of an immediate reaction to a food. 80 to 90% of all food allergy is just diagnosed on history. We don't need to do any testing, blood testing, skin prick testing. It's all in the history. So the history generally is exposure to a known allergen, and that's one of the major 14 allergens, plus legumes. So legumes, a big underestimated cause of food allergies. So things like peas particularly, and pea protein gets in things like Billy Bear ham. Chickpeas, lentils, those three all tend to go together. And then beans. And also we'll see kiwi. Kiwi is another one of those allergens that isn't recognized as a major allergen, but we do see it quite often. So timing, so immediate reactions to foods generally occur within usually 10 to 15 minutes. Occasionally I've seen a good going urticaria to foods like cashew nut, sort of an hour, maybe up to 2 hours later. But generally it's pretty quickly. You'll get this good history of eating the food, had a reaction. And the children don't like eating the food. It's not like, oh, they're happy to eat the food. They kind of spit it out or may claw their tongue, and then they'll get this immediate, usually starting around the mouth, redness with urticaria. So urticaria, raised bumps. It's raised, it's hive-like, it's itchy. They don't like it. They may sneeze, runny nose, itchy nose. They may, in extremis with anaphylaxis, have breathing difficulties, wheezing, coughing, shortness of breath, hoarse voice, drooling, loss of consciousness. The environment, so we always ask about the environment. Were they otherwise fit and well? Was there anything else in the environment? I've had children react, for example, to a homemade sort of chicken soup, but actually it wasn't the chicken soup. They'd had that chicken soup multiple times before. It was the fact that mum was eating scrambled egg at the same time. She was putting the soup to her mouth. She was checking it to make sure it was the right temperature, and then she was giving it to the child. The child had anaphylaxis to egg. Reproducible. So generally food allergies occur on the first exposure. Very occasionally it'll be the second exposure. Why is that so? So generally we become sensitized through our skin or through breast milk. So you don't need to have eaten the food beforehand to have an allergic reaction. And what people think, and what is a kind of a common myth is, oh, the next time you'll have the food, it'll be a worse reaction. Well, actually, that's not true. And generally it's a milder reaction because children know to avoid it. One third of reactions to, for example, nuts are severe, but actually that means that 2/3 are always going to be mild. And it's not the food that gives rise to the symptoms. You can have mild symptoms to cashew, or you can have severe symptoms to cashew or kiwi. What matters is how much you eat, but also, do you have asthma? Is your asthma well controlled? Are you otherwise unwell? Have you sleep deprived? Have you just had exercise? Are you taking any drugs or non-steroidals in particular? So there are cofactors which can make reactions much worse, but generally it's how much they eat. And for example, if it's in a matrix, like a chocolate-covered matrix, where they don't actually realize it's in the food. So you could have, for example, you could react to a small amount of peanut butter because you can taste that peanut butter and you don't like it, so you don't eat it. But actually, you may have a worse reaction to something like a Snickers bar because you don't realize there's chocolate with it, there's a peanut within the chocolate. So the symptoms are generally reproducible. The exception to that will be things like pollen food syndrome. And I'm not going to go through pollen food syndrome. Happy to talk about it at the end. But pollen food syndrome occurs generally in individuals with a pollen allergy, as the name suggests, more often seen in teenagers who have hay fever, generally spring, summer hay fever. And what tends to happen is they become sensitized to pollens. Generally it's birch pollen, sometimes it's grass pollen. And then when they start eating foods which contain the same proteins, they start reacting. It's as if you're eating a big bit of pollen. So the body says, oh, actually, that's not such a good thing to eat. And so then you can start reacting to things like cherries, fresh apples, fresh onion, fresh carrot. Sometimes it's nuts as well. But generally the threshold is quite high, and 96% of these reactions will always be mild. The exception to that is if you've got seasonal asthma, in which case the pollen that you're eating can give rise to an asthma exacerbation or anaphylaxis. And then symptoms. You want to see typical symptoms. You want to see the urticaria, the angioedema. You want to kind of hear about the itching. You want to hear that actually they didn't really like the food, or if they had a history. You always got to ask about, were they pale, floppy, were there any breathing difficulties? And always ask about wheeze. And what parents will tell you about wheeze is, oh yeah, they were wheezy. I'm like, well, that's not quite wheeze. That might be stridor, but wheeze is generally an expiratory sound. And sometimes it's just due to secretions, that they're kind of having lots of upper airway secretions, and it's just noisy breathing, so not necessarily anaphylaxis. So these are the top 14 allergens, much more skewed towards adults, I think. We rarely see shellfish allergy. In fact, we only see it in conjunction with either a dust mite allergy or a fish allergy. Sulfite allergy, the thing to note about sulfites is that it tends to be more of a chemical reaction rather than an immunological reaction. Doesn't give you a rash, tends to give you tummy pain and coughing. Celery we only see very rarely, but it can be in things like tomato ketchup. Mustard, again, very rarely unless you've got an associated seed allergy. And the rest we see. We see lupin, but very, very occasionally. Lupin is a bean, so it kind of goes with that whole legume allergy. It's more evident in children who've got a peanut allergy. And we tend to see it in imported packaged goods like apple pies, which have got lupin flour in. We use soya flour in the UK. Overseas, they tend to use lupin flour as a kind of a bulker out in terms of protein. So as I said, IgE symptoms, urticaria, angioedema. When we've done studies in adults looking at deliberately challenging them and looking at cofactors, the first sign they always seem to demonstrate is they'll be happily, having their doses, sitting on their computer, and then they'll put their computer down. They'll close their computer. Something is going on. Even before they have any symptoms, before they can articulate what's going on, they'll have this behavioral change. And children can, again, be very kind of withdrawn and just change in behavior, even before you'll see any urticaria, angioedema, vomiting, or vocalizing of tummy pain. And then, so reactions tend to be two types. We tend to call them mild to moderate reactions, and then severe reactions. And the severe reactions are the anaphylaxis. So onset, generally within minutes, certainly less than 2 hours. Very occasionally, you can have an immediate reaction to foods or an IgE-mediated reaction to foods, which is delayed. So things like that. So that would, again, seen in adults, and that seems to be meat. Mammalian meat can give delayed reactions. And the typical history is the adult wakes up in the middle of the night with breathing difficulties, covered in urticaria, goes to the toilet and collapses. So that's secondary to tick bites, alpha-gal. So just a little reminder about what happens with urticaria. So if you get persistent allergen exposure, you tend to get tachyphylaxis of your mast cells. So those mast cells that are sensitized, they just keep degranulating to the point where there is no further histamine in there. So you don't get any further urticaria. What you do get is eczema. So children with eczema, particularly breastfed children, they don't tend to present with urticaria unless they have like a big dose of the allergen. So they tend to present with this kind of grumbling eczema type symptoms. And really, the way to diagnose that, sometimes they'll be positive on skin prick testing or blood testing, but the way to diagnose that is you take it out of the maternal diet. Does the eczema get better? You put it in again. Does the eczema get worse? And eczema tends not to be a mast cell mediated condition. It tends to be an inflammatory condition where the allergic inflammation is pulled into the skin, and that causes the activation of nerves, and it's the nerves which cause the itching. So mast cell stabilizers or antihistamines, generally not very effective in eczema. They are prescribed. Our dermatology colleagues do like them. They are NICE approved for short periods of time, up to a week, using something like Piriton in young children. And the reason for that is that actually sometimes breaking that itch-scratch cycle can actually help your eczema. So we know that actually just the physical act of itching itself will activate the bone marrow and cause more inflammation into the skin. So what you want to do with these children with eczema is get on top of that itch straight away. Go ahead.
Should we be considering dietary triggers for any child with eczema?
No.
We've always been told by dermatologists that we shouldn't be. So
So 3 months.
3 months.
Yeah.
Okay.
So I would say 3 to 6 months. Yeah. Once you've been clear or kind of that first year of life, if you then develop your eczema, it almost invariably that will be dust mites, unless you've introduced like fresh milk. Occasionally in those cases, fresh milk can trigger it, but almost invariably that eczema will start kind of, we say early onset, less than 3 to 6 months of age. So if you do get your eczema, and you can see here, birth to 3 months, 4 to 6 months, 6 to 9 months, 10 to 12 months. So it depends on how severe your eczema is to what your risk is of developing food allergy at 1 year of age. And you can see that the highest risk is if you develop your eczema sort of birth to 3 months of age, particularly if you need strong topical corticosteroids. So the worse your eczema is, the more severe your eczema is, the earlier you get it in infancy, the higher the risk you are of having a food allergy aged 1. And that's the reason why we like to see children early, and we like to get on top of that eczema as soon as possible. There was a Japanese study done a couple of years ago which showed if you covered children in a potent topical steroid from birth, so children with obviously severe eczema, if you just covered those affected areas and non-affected areas with your topical steroids until they're 1, their incidence of food allergy dramatically reduces. They don't grow very well, but they don't have any allergies. So we don't advocate that. So this is just a recap of how to recognize an allergic reaction. So I've just been talking about IgE mediated. I mentioned non-IgE in terms of FPIs. So we don't tend to see non-IgE mediated food allergies. And that's because actually allergy testing isn't indicated. It's going to be negative. Parents come away thinking, I've waited 6 to 9 months. I've had my test, it's negative, but now they're telling me that actually that doesn't rule out a food allergy at all. So non-IgE mediated food allergies are only diagnosed by taking that food out of the diet, seeing if it gets better, putting it back again in the diet, and seeing if it gets worse. So and generally, sort of non-IgE mediated food allergies generally affect the under ones. Once you've got those foods into the diet without any symptoms, it's difficult then to lose your tolerance and then start reacting. Occasionally you will, and you will get sort of grumbling gastrointestinal problems, particularly abdominal pain, nausea, and even dysphagia. So I always ask about other things, so like early onset eczema, other atopic diseases, parental family history of A to P. And so girls, less likely to have allergies. We see 2 boys to every 1 girl in our pediatric allergy clinic. I have no idea why. Obviously, there's a sort of a hormonal contribution. But if there's no family history of A to P, there's an unconvincing history, and they don't have eczema, it's unlikely to be a food allergy. Doesn't mean to say it's never going to be a food allergy, but it's unlikely. So where not to refer? So the controversial one, family history. So we quite often get referrals, please see this child. Mum, dad, anxious about a food allergy. Mum or dad, usually dad, has got an anaphylaxis to peanut, cashew, whatever. Please can you advise? And the advice is, actually, in the absence of early onset eczema, the advice is actually to get that food into the diet in a safe manner. Obviously, we wouldn't, if dad's got a peanut allergy, we wouldn't be advocating dad to start giving the child peanut. Obviously, it has to be done in a safe manner. But actually, food allergy, as I'll show you, a family history of food allergy isn't a risk factor for the child having a food allergy, and I'll explain that why. IgE, non-IgE mediated food allergies, so we don't tend to see those. Under ones, we tend to recommend they go to the community dietitians after a convincing trial of taking it out of the diet. Do they get better? Putting it back in again. Irritant reactions, I'll go through that. So viral urticaria and angioedema, we get a lot of these referrals from ED, not so much from primary care whatsoever. And they'll pitch up to ED with this kind of urticarial rash. And and we might, they'll think, oh, actually, it was because of the peanut yogurt they had 3 days ago. And sometimes we'll see them, but actually they'll generally not turn up because actually by the time we see them 6 months later, the rash is clearly gone. They've eaten that kind of yogurt again, and actually nothing's happened. So viral-induced urticaria, the rash is urticarial, but it persists. It generally persists for like 3 to 5 days, whereas in a food-induced reaction, once that food has been eaten, that rash persists for 20, 30 minutes, and then it goes. Hay fever. So as I said, I'm going to talk about hay fever, pet allergy, another very emotive subject, and we'll just touch on that. Asthma. So we don't tend to accept children, for whatever reason, they've had a blood test done, and it just shows a raised total IgE. Total IgE can be raised for numerous reasons: asthma, eczema, hay fever, kind of parasitic infections. In the absence of symptoms, we're not going to go chasing, the reason why. Actually, treat the child, not the blood test. And then we're happy to see venom allergy. So bees, wasps, happy. But actually, if they're anaphylaxis, happy to see them. If they're just large local reactions, so delayed reactions, actually, that doesn't increase your risk of having anaphylaxis to the point where we would actually consider immunotherapy. And we wouldn't do any testing in that case. So a couple of years ago, we did this kind of service review. We were under pressure to reduce our waiting list. And then we had a look at what we redirected back to primary care, secondary care. And so the most of those were viral-induced urticaria, non-IgE, had symptoms, but it was unlikely to be allergy or unclear. Or they had hay fever, but actually they weren't on maximum treatment. The other one is private allergy testing. We always get some children referred every year. They've gone abroad, they've had allergy testing done. There is no sort of aftercare where they've had their testing done, so they just come in with this whole sheet, usually full of testing. Sometimes it could be allergy testing, sometimes it could be other testing, and they kind of expect us to go through it and tell them exactly what they can eat and what they can't eat. So this is family history, and you can see this blue one, that's family history of peanut allergy. This was a recent publication, 2021, and you can see the risk of peanut allergy is 1%, where there's a family history of peanut allergy, but no moderate to severe eczema. And in fact, the incidence of peanut allergy amongst the population is somewhere between 2 and 3%. So these children have a reduced risk of having peanut allergy. And the reason for that is the big risk factor for peanut allergy is not only early onset eczema, but actually it's if you eat peanut butter at home. That peanut butter is very sticky. It increases your risk of having a peanut allergy by about 20-fold if you've got eczema. And it just gets everywhere. So if we measure amounts of peanut protein in the bed, for example, there's a clear correlation with risk of sensitization. So if you are kind of going to eat peanuts, I would recommend in a coated form. So peanut coated, so chocolate coloured peanuts, absolutely fine. Snickers bars, other peanut coated chocolate bars are available, absolutely fine. So non-IgE mediated food allergies, I forgot to put anything on that slide, but the one I would just make you be aware of is eosinophilic esophagitis. So eosinophilic esophagitis, very rare, becoming more common. It's probably as common as inflammatory bowel disease, and it presents usually around 7 to 15 years of age, normally boys, normally Caucasians, much rarer in girls and non-Caucasians, and it's typified by abdominal pain, slow eating, early satiety, water chasers, dysphagia. And these children kind of adapt their behavior, and it can be several years before it gets to the point where they actually suffer from an episode of dysphagia. The food will not move, and actually somebody has to go down there with a scope, and when they scope them, it may be normal, but actually, hopefully they'll biopsy them and they'll see evidence of this eosinophilic inflammation. And that in 50% of individuals is associated with milk allergy, and taking all dairy products out of their diet will help in 50%. The other treatments are PPIs and steroids. So, because I thought this was going to be an intimate occasion, I thought I would just show you this child. Harriet is the daughter of my colleague, and it's actually not this picture at all. So 2-year-old girl, 6-month history of acute urticarial rash, and I put urticaria in question marks, with mild lip swelling to tomato ketchup. Strictly avoids all tomato-based, but actually when you take the history, actually she really enjoyed eating the ketchup. There's no other history of atopy, and if you look at the pictures, this is just a red, flat rash. She doesn't itch. There may be some mild lip swelling, again, very subjective, but actually this is much more likely to be an irritant type reaction. And generally we'll just kind of send them back, kind of reject the referral and say, 5 minutes. We don't need to see these children. Sometimes if they'll pitch up in clinic, we'll do the prick-to-prick test to the tomato sachets that we have available, and then give them a tomato sachet, and then just show them, actually, it's fine. It's just a rash. They can continue eating it. This is a nerve-mediated condition. It's not an immunological condition. You're not activating mast cells. You're not potentially causing anaphylaxis. This is just irritant. And we have a little algorithm there. Lots of different causes of urticaria, immune-mediated and non-immune-mediated. That's our ICB hay fever guidelines, and at the end there's a reference list. You've got a link to that. This is just a child, again, pet allergy. We get lots of referrals, pet allergy. Pet allergy is a clinical diagnosis. You walk into a room where there's pets, you start having symptoms, usually respiratory symptoms, runny nose, itchy nose, sneezing, wheezing. But parents want a test to show that actually it is the cat, because they're very reluctant to rehome the pet otherwise. To be honest, they're very reluctant to rehome the pet. Even if you tell them that's definitely a pet allergy, they're very reluctant. And pet allergy is very common, sensitization is very common, and as I said, it's a clinical diagnosis. You tend not to have immediate symptoms to your own pet. That's the issue. You've grown up around pets, and as I said, your mast cells have all just degranulated, so you tend to have delayed symptoms, and the delayed symptoms are asthma, so inflammation within the lungs, inflammation within the nose, so you get persistent nasal congestion, or eczema, rarely eczema. And you know it's the cats, because actually you go on holiday and all the symptoms go away, you come back and the symptoms come back. And we see this in teenagers that go to university, that kind of leave their cat at home, come back, and then they start sneezing and itching when they're in the same room. And you get tolerance to your own cat, but not other people's cats. So atopy, Doesn't always equal allergy. You can have lots of IgE antibodies. Doesn't mean to say you're going to be allergic. This is a child that developed an acute urticarial rash, had a whole Ferrero Rocher. You've got to know your confectionery if you're working in pediatric allergy. So this contains hazelnut, 2 forms, roasted and unroasted, but the rash started 6 hours later. But he had a blood test, which is completely frightening because it shows massive sensitization to hazelnut above 100, grade 6. So they're definitely going to react. Well, actually, no. This child is happily eating Nutella. This is not a history of a hazelnut allergy. He ate it. It was 6 hours before we had the reaction. This is more likely to be to a pollen-induced urticaria or a viral-induced urticaria. So you certainly wouldn't give him EpiPens. You wouldn't tell him to stop eating nuts. He's happily eating nuts. And you wouldn't necessarily throw him to allergy because just on the basis of blood tests. So treat the child, not the blood tests. So various alternative allergy testing. And this is a child with a cat allergy. Had a cat allergy. So they were 6 months of age when they started going to see a private allergist, and then didn't believe that allergy testing, came to us, and indeed skin prick testing. So I am going to wrap it up here. That this is probably only halfway through my slides. There is a lot more about EpiPens, when to prescribe adrenaline autoinjectors, the new Euronephi, the potential for intranasal adrenaline, which will stop that anxiety about EpiPens, how to use it. These are the treatment plans you can download. And then just a little bit about prognosis, anticipatory testing, bit of a recap, egg allergy and vaccination. So the bottom line is MMR, absolutely fine. Nasal flu vaccine, absolutely fine, unless you've gone to PCCU with egg allergy, which is vanishingly rare. And the only one that we wouldn't give was the intramuscular flu vaccine, but there is a low egg version. We avoid rabies vaccines and which contain egg, but there's an egg-free version, but the yellow fever is the one we worry about. And that's just a list of places you can go for help. Or you can just email me.